So good afternoon, everyone, and thank you for joining us for our 9th workshop for this rulemaking. My name is Amelia Boyd. I am the program manager for the WMC and the facilitator for today's session. This workshop is being recorded and we'll post the recording to our YouTube channel soon. The documents we'll be discussing are available on our website at wmc.wa.gov. In this slide deck, the globe, which links to our website, and YouTube icons are clickable and will take you directly to those resources. For attendees, if you'd like to ask a question or make a comment, please use the raise hand function. We'll call on you as soon as we can. When offering comments, please avoid reading aloud any written remarks that are already included in the materials. These workshops are intended to be collaborative with a back and forth exchange of ideas about the proposed language. Before we get started, I'll take a roll call of our panelists and staff. When I call your name, please introduce yourself. So we'll start with Dr. Chang.
Hi, I'm Poshan Chang. I'm a family physician. I'm one of the commissioners.
Thank you. And go ahead, Danielle.
Hello, I'm Danielle Hacker. I am the administrative assistant for the Washington Medical Commission. It's nice to meet you all.
Thank you. Heather.
Good afternoon, Heather Carter, Assistant Attorney General, Legal Advisor.
And Kyle.
Good afternoon, everybody. I'm Kyle Kiernan. I'm the Executive Director for the Commission.
Dr. Khan.
Hello, everyone. My name is Kutsiya Khan. I'm an internal medicine and addiction medicine doc, and I'm one of the commissioners.
Mr. Lopez.
Hi, good afternoon, everyone. My name is Ed Lopez. I'm a PA hospitalist and vice chair of the commission.
Micah.
Good afternoon, Micah Matthews, Deputy Executive Director for the Commission.
Thank you. And then I'll go ahead and ask our presenters, Cindy and Rose, to introduce themselves real quick.
Hi, my name is Cindy Hohenhaus, and I'm part of Washington Patients in Intractable Pain, or WashPIP. We help represent the patient voice at various times where we're needed.
And I'm Rose, and Cindy underplayed. She and I both co-chair WashPIP, not just members of. So yeah, it's what she said, same.
Thank you. And Jeb is also a presenter today. If you'd like to go ahead and introduce yourself.
Good afternoon, everyone. My name is Jeb Shepard. I'm the Director of Policy at the Washington State Medical Association. We represent over 13,500 physicians and physician assistants practicing in every care setting across the state of Washington.
Thank you. And Ms. Blake, if you would introduce yourself and then start the script.
Alrighty, thank you, Ms. Boyd. Good afternoon. My name is Christine Blake. I'm a public member of the commission with a background in healthcare administration, and I will be the presiding officer for this rules workshop. Today is Monday, August 10th, and it is 1:04 p.m. This meeting is being held by Teams webinar. The rule being discussed today is regarding opioid prescribing general provisions in both Chapter 246, 918 WAC for physician assistants and Chapter 249, 919 WAC for physicians. The CR 101 or pre-proposal statement of inquiry. Oh, I think I just lost that. Was filed as WSR number 25-10039 on April 30th, 2025. Sorry for the interruption there. Ms. Boyd, please present our proposed timeline for rule development.
So here's our proposed timeline for this rulemaking, which has been adjusted since the last workshop because we added a couple of new workshops. If there are any questions about this timeline, please use the raise hand function and I will call on you.
Thank you, Ms. Boyd. Just a reminder that we do have future workshops scheduled for this rulemaking, which Ms. Boyd will present later in the workshop. The next item on the agenda is a presentation from the Washington State Medical Association. Jeb Shepard, if you would like to begin, please.
Yeah, thank you so much. Again, Jeb Shepard from the Washington State Medical Association, representing 13,500 physicians across the state of Washington. Thank you, commissioners and medical commission staff. We really appreciate time on the agenda today to discuss the August 3rd letter that is in your meeting packet. I hope folks, both the commission staff and folks in attendance today, have had an opportunity to I don't have any slides or a formal presentation. I'd just like to share the letter with you today, provide an overview of the concept that we're proposing in the letter. You know, this is a workshop, so this is not something that we're looking for a final decision on. As Amelia said, this is sort of an opportunity to exchange ideas and discuss concepts. And so I probably won't need full 30 minutes if that helps with your agenda planning today. A quick note before I get started, I was supposed to be joined by Dr. Nathan Schlicker. He's the Chief Clinical Officer of Better Prescribing, Better Treatment. It's a joint quality improvement program around acute opioid prescribing ran by the Medical Association, the Healthcare Authority, and the Department of Health. He was pulled into an emergency meeting, so he's not able to join me today. So I will focus on the regulatory elements of our proposal, but we'll need to defer any clinical questions, any patient care questions to a later date. We can follow up with him, or if there are any other physicians on the call who would like to jump in. More broadly, as we've expressed throughout this work, is we appreciate the Commission's work and engagement with stakeholders and the consideration of our letter that we submitted last week on behalf of physician leaders from across Washington. That includes representatives from the Washington State Medical Association, Better Prescribing, Better Treatment, the Washington State Hospital Association, UW Medicine, Harborview Medical Center, the Washington Academy of Family Physicians, and several other medical specialties. I'll review the concept that we present in our letter and then take a deeper dive into the various pieces of it. But simply put, the ask in our letter is for the Medical Commission to consider separating enforceable legal requirements for opioid prescribing, including those that are required by the legislature in statute, from a lot of the clinical recommendations and best practices that we feel are included in the 50+ page rule, with the goal of creating a clearer, more navigable regulatory framework. Again, we're not asking for a decision today, but would welcome a discussion among the commissioners and would be open to a follow-up conversation about whether and how this could be pursued at a future rulemaking. I want to be very clear on what we're not asking for in our letter. We are not proposing that you deregulate opioid prescribing. I want that to be crystal clear. We recognize the importance of appropriate safeguards. We recognize the Commission's responsibility for patient safety. And we recognize that the legislature has established requirements the Commission must implement. Where the legislature has said something needs to be in rule, we recognize that it belongs in rule, and we're not asking the Commission to disregard any statutory requirements. The concern that we are raising today, as we have been raising since 2018 when we were first working through the original drafting of these rules, is how the regulatory framework is structured, not whether or not opioid prescribing should be regulated. I want to be very clear on that point. I also want to acknowledge that we understand the CR 101 for this rulemaking is relatively narrow. We agree that some of the things that we're proposing in our letter may not fit within the current scope of that CR 101, and we're certainly not asking the Commission to exceed their authority under the current CR 101. However, if the Commission believes that the broader concept has merit, a subsequent rulemaking could be warranted. That's certainly within the Commission's purview, and we'd be happy to have that conversation. So again, like not something else we need to solve today. That's a procedural question, but we would like to discuss whether or not the underlying concept that we're proposing is worth pursuing. One question, I've been in almost all of these workshops, and one sort of question that gets raised as we talk about improving access to appropriate opioid prescribing is, have the opioid prescribing rules worked? The question has been, have the opioid prescribing rules worked? Have they contributed to achieving the legislature's objectives? And my answer to that question would be yes. I'd say they've been an important part of the effort to address overprescribing, but they didn't operate in isolation. It wasn't just the medical commission, the other boards and commissions, the legislature working on this. Other factors include physician organizations' prescribing initiatives, including better prescribing, better treatment, hospital and health system quality improvement, Medicaid payment and delivery policies, insurance policies, specialty society quality improvement, CDC and other national guidance have all led to broader changes in clinical practice. These rules have been one component of a much broader effort that has resulted in lower opioid prescribing. But before I dive in to the actual meat or the actual substance of our requests, I kind of want to think about that question differently. I don't think whether or not we've lowered the amount of opioid prescriptions is the question we should be asking. I think the question we should be asking is, have we achieved the patient safety objectives of the legislature and others while preserving access to appropriate pain management? And that's particularly important because improving access to appropriate pain management is one of the commission's stated objectives in opening these rules up initially, opening this CR 101 up. And I don't think we need to choose between acknowledging that the rules, what the rules have accomplished, while also asking whether they've also created unintended barriers to appropriate pain care. So why are we raising this concept now? Most of us were around in 2019 working on these original rulemaking that went into effect in 2019. That was a very serious time during the opioid epidemic. We understand the rationale for those safeguards, but we've had several years of experience under that framework. And our members report that they experience the rules as complex, they're difficult to navigate, and they're administratively burdensome. That complexity contributes to uncertainty, and in some cases could contribute to hesitation in prescribing opioids when clinically appropriate. It's an important distinction. Our concern isn't necessarily that an individual provision of the rule is unreasonable. It's the cumulative effect of the regulatory framework. So the repeated layering of shall and must provisions across multiple phases of care is not individualized care. In the current rules, there are 109 mandatory directives, that's shall or must. There are 33 advisory directives that should, and 41 references to documentation. So that's a document, documented, documentation, or documenting. As we've observed this current CR 101 that's intended to improve access to pain management unfold, we feel like it's going in the opposite direction and that it's adding more complexity. So the framework continues to blend enforceable legal requirements, clinical recommendations, and best practices. There's a question in the letter that we feel is the fundamental question that physicians should know the answer to every single time they go to prescribe an opioid. And that is, what am I legally required to do every time I prescribe an opioid? Today, when answering that question, you have to navigate dozens of pages of regulatory text, multiple exceptions, and provisions that often blur the distinction between mandatory legal requirements and recommended clinical best practices. The law should tell physicians what they must do, and guidance should help physicians understand how to provide the best care. So our proposal to the Medical Commission is to bifurcate this regulatory structure into one, a clear enforceable rule that should contain all the statutory requirements as laid out by the legislature, the requirements that the commission determines are necessary for patient safety, minimum enforceable standards, and things physicians are legally required to do, and then a separate clinical guideline. And this is not something that you'll have to create fresh. There is a tool at the Medical Commission and other regulatory bodies, the Department of Health, called a clinical guideline. Those could obtain clinical recommendations, best practices, examples, explanatory information, and can be updated much easier with additional clinical considerations. So that's the core proposal in our letter, is to bifurcate the regulatory structure of opioid prescribing into one, a clear, concise floor, and two, a clinical guideline that contains everything else, all the shoulds, things like that. Again, this is not proposing deregulation. Why? Because patient protections remain, statutory requirements remain, the commission retains authority to establish enforceable standards. The difference is about what requires the force of law. Asking the commission to lower the floor, we're asking the commission to clearly define what the floor is. This helps with compliance. Clearer rules are easier to comply with. Complexity itself can become a barrier to care. Physicians are more likely to consistently follow requirements they can readily understand. Separating requirements from recommendations reduces uncertainty. We're not asking for fewer requirements. We're asking for requirements that physicians can actually identify and understand. This would help clinical care. Physicians should be able to focus on the patient rather than worrying about whether they missed a regulatory requirement in a 50+ page rule. Greater clarity can increase physician confidence that supports the commission's goal of access to appropriate pain management as outlined in the CR 101. We want physicians thinking about what the patient needs, not whether they, again, inadvertently missed one of dozens of provisions in this rulemaking. So that's the rulemaking piece. Guidelines matter. Medicine changes faster than administrative rules. It takes much more time and effort to update WAC, as we've experienced over the last year working on this particular 101. Clinical evidence evolves, national recommendations evolve, specialty practice evolves. We're not proposing less clinical guidance. We're proposing putting the clinical guidance that already exists in the rule in the place where it can actually evolve alongside with medicine. And the letter makes that point explicitly. This is a workshop, so it's an opportunity to share ideas. What we're asking for today, or I guess what we're not asking for today, is a decision. We're not asking for a vote. This is a workshop. This is not the appropriate venue for the commission to make that decision. Not asking you to rewrite the CR 101, not asking you to adopt the bifurcated structure today, but we are asking for the commission to start thinking about or discuss, does this concept have merit? Specifically, is there value in distinguishing enforceable requirements from clinical guidance? Is that a useful framework? If so, what could that look like? What belongs in the current rulemaking? What might require subsequent rulemaking outside of the current CR 101? What might the pitfalls of this approach be? Concerns with approach like this? And finally, as outlined in the letter, you all have been really great partners on this opioid prescribing rulemaking since its inception in 2016, 2018. With, I guess, the latest iteration through 1427. You all have been very collaborative, and we want to continue to have that collaborative relationship with the Medical Commission. We want to work with you all. If you decide that there's merit in this, we could help you identify what belongs in rule versus guidance, help develop physician education. I think that's where the stakeholders on the letter could be particularly helpful, is making sure that physicians understand the new regulatory structure, what's expected of them, help with that implementation, help make sure physicians understand both the legal obligations and the clinical recommendations. In closing, finish with a few points just to underscore a few things. We're not proposing deregulation. We're not asking the commission to disregard statute. We're not asking you to exceed the current CR 101. We're asking if there's a better way to distinguish legal requirements physicians must follow from clinical guidance that helps them provide excellent care. The rules have been one part of a much broader effort that has decreased opioid prescribing. Success shouldn't be measured only by whether the prescribing has gone down, but we also need to ask, which is the whole point of the CR 101, is whether patients who appropriately need pain management can access it. And finally, not looking for a decision today. We appreciate the commission discussing whether or not this concept has merit, either here or at one of your future meetings. And if you do think so, would love to have a follow-up conversation with the commission and staff to see what it could look like and what process would be appropriate. So that's my piece for today. Again, thankful for the opportunity to have some time on the agenda to present this concept. Happy to listen to any conversation or answer any questions you might have.
I don't see any hands raised, Ms. Boyd. I don't know if you do.
I do. Cindy, go ahead.
Yeah, I was just asking, we're talking about the floor, you know, the minimum requirements. What do you have any ideas of what those might be yet?
It's an excellent question. I think at a minimum, it would be what the legislature has required in statute. That has to go in there. When we were drafting this letter, we talked about whether or not we could start like proposing what belongs better in rule and what belongs better in guideline, but we decided that that's more of a collaborative conversation that would need to happen. So we don't have any sort of specific examples beyond the statutory floor created by the legislature.
Yeah, so I'll add on to what Jeb said. Dr. Schlicker, apologies for my tardiness. I was stuck in another meeting. So I think the clear example is, for instance, checking the PDMP, for history as an example, something that's statutorily required that we would include in the base example, doing an adequate history and physical and not just doing remote telemedicine. So those kind of things, but then leaving as much as we can in the guidelines so that we have the opportunity for clinicians to have discretion. And as Jeb said, I think the key thing is we want people to feel like good intent, good work, and good effort to comply with the rules and guidelines won't result in them being dinged for a technicality of not crossing a T or dotting an I. So let's keep the goal of doing good medicine, but not create a regulatory framework that disincentivizes participation in pain management for those that need it.
Go ahead, Rose.
I was just going to say, I think for clarity, the only place that a statute requires checking PDMP is for Medicaid patients because of the Support Act. Because we just looked at the WACs, and the WAC for checking the PDMP for pharmacists, at least, is only enshrined for Medicaid patients. So if we want that for all patients, that's a whole other thing because it's not in the statutes.
That would be a part of the discussion, I think, around what belongs in rulemaking. I think, at least as it pertains to House Bill 1427, it's pretty broad. It just says that the agency shall promulgate opioid prescribing rules. I think the chronic ones from earlier, 22 or so, are more prescriptive. But that's the discussion that we'd like to have, is what belongs in rule and what belongs in the guidelines.
So I have a question. So Dr. Schlicker, you mentioned, prescribers are worried about being dinged. Is that something that has happened frequently with WISMA members, that they've not followed what's in rule right now and they've been disciplined, or a complaint has been filed or something like that?
I think it's not about whether or not a disciplinary action has happened. It's about the fear of a disciplinary action. And as we, I think it's fair to say that people fear going before the medical commission, their license being at risk. That's a very reasoned understanding. They spent their career and their life trying to do good medical care. And when I look at something like the rules as they exist today, that Jeb, you have the appropriate count, but has over 50 instances of shall in it and is hyper prescriptive, I worry about whether or not I can comply with it as a lawyer and a doctor. And so I don't have to make the decision about whether or not I do chronic pain management because I'm an ER doctor. If I was being forced to make that decision about do I want to lose the ability to care for all of my other patients that I feel like I'm doing good work for, managing diabetes and hypertension, hyperlipidemia and cancer and end of life and pediatrics, to take on this area that the state has felt the need to overregulate, that would be a tough moral equation to work through. And I would have to strongly consider whether or not I would be able to participate in this care. And so I just think that, there was a good intent. We expressed at the time this hyper-regulatory environment is going to lead to adverse events. I think we've seen that with systems pulling back and individual clinicians pulling back from care in this area, as Rose and Cindy have shared over our conversations over these last year and a half. And it doesn't have to have a bad outcome to have fear drive it, right? So I think if we want people to re-engage in this process, we need to come into it and say the medical commission, the medical association want appropriate pain management. We want appropriate opioid dependency treatment. We want your engagement, primary care in this environment, in this arena. And we're not saying you have to prescribe. We're not saying that you can't use good clinical judgment. We're not saying that you can't say no, but we want you to feel like you can say yes. And I think right now, many clinicians look at the rule and they feel like the only right answer is no. And that's not a good place for our patients or for the practice of medicine.
Thank you.
Any other comments or questions from our commissioners either?
Go ahead, Dr.
Stephen.
Stanos.
Oh yeah, no, I'll just make a comment. And I appreciate what Nathan and Jeb talked about, especially I can agree with the fear that physicians have. And we see that with a lot of the primary care clinics, despite us doing a lot of outreach about the rules. We've told them now that the rules are going to be, adjusted apparently in the next year. But even before that, I think it's always, for some physicians, they'd rather say, I'm not going to do it. And we have a lot of patients that are saying their primary care providers are really not providing anything for them. And God forbid if they had to give them opioids for a short time. So I do think the fear is more important, separate from getting a letter from the state, saying you're in the top whatever percent because you prescribed opioids, which a lot of those lists aren't really accurate. And that also, I think could make a physician or APC even more kind of resistant to take care of patients, even if it's one or two patients. So I do think the key would be from us that in Swedish, we are seeing that there is a fear. And so how can you simplify this so they can appreciate that? And for sure, updating the AMDG guidelines, AGM, Agency Medical Directors Guideline would be great. I think it's definitely overdue. And the environment has significantly changed since then. And we could just make an updated, even better one than it was even before.
Go ahead, Kyle.
Jeb, Dr. Slicker, I apologize, but as you know, this particular program is housed outside of the disciplinary authorities. I had heard rumors that the Better Prescribing, Better Treatment program was being mothballed. Is that accurate? Again, I can also talk to the department about it. They don't typically talk to us about those sorts of efforts writ large, but I know that WSMA and Dr. Slicker, we've talked to you on a couple different occasions about some operational issues with regard to that program. Do you know, is that program going forward?
We have not expressed any intent to mothball it. The state adjusted their funding this year. But no, it's still funded through the end of this biennium. So our intent is to continue to work with folks. I find the conversations we have very enlightening. Most clinicians want to improve and based in education, and that's what we reinforce to them. they want to know what they can do better, or recognize that their data, they're a hospice doc, even though they're listed as FP, and we can talk about that and provide them education around, even in hospice, we can be thoughtful about opioid prescribing so that there's not a second victim effect, or we can give them data that's reflective. So, we still continue to have good conversations. We still continue to work on the other side of it, of giving encouragement for people to do buprenorphine treatment, and showing folks where they're at compared to their peers and their specialty, so that they see that as a piece of their toolkit. So I think education is always the venue where we advocate for things to be, unless there's really egregious behavior. And we've looked at some of those commonly together and shared our thoughts. And I think most clinicians are trying to do the right thing, and where there's an opportunity for improvement, I hope that us being outside of the government structure and being peer-to-peer has yielded more collaborative conversations. And I've enjoyed the conversations with clinicians 99 out of 100 times.
Not speaking for the commission in this particular comment, just for myself, Jeb, I do think that particular program is a contributing factor. It's one of the contributing factors you mentioned, and I'm just echoing that after being in this space for 15 years plus. I do think that it's been helpful, and I do think it's constructed in the right way, even if there are, criticisms of it. So I do hope that WSMA continues running it, because I do think it has been a contributing factor to helping clinicians understand the overall landscape when it comes to opioid prescribing. So, thank you.
Happy to be a partner.
Out of curiosity, as Chris Blake, from a hospital standpoint, and I'm not sure if I have the right audience here, folks are boots on the ground in the hospitals, but I know that hospitals are also taking a look at opioid usage by provider. I think it's part of the quality review that happens at reappointment time or whatever. Are you hearing anything from folks on what's happening in the hospital side as far as how they're regulating opioid use and tracking that from a provider standpoint?
So the group that I know has been doing reports for as long as we have was Kaiser Group Health at the time, and we haven't heard from their clinicians adverse effect that I'm aware of. Not that I can speak to all of it, but they've been doing this similar work. We've partnered with a lot of hospitals, and they've used our data, and I would say trusted us to educate the clinicians on that. So I've not seen. I sat on our medical executive committee for 7 years, chaired our peer review for the same time in the Franciscans in the Legacy 5, and I can say that we did not discipline anyone based upon opioids. The few cases that were involved, we provided education, but we're only one health system. I'm only one health system, so I can only speak to that one. Dr. Stanos is in another health system, and I sense he has a different thought.
Okay.
Can I comment? Is that okay?
Please.
Yeah, we probably have better data for discharge prescribing, and we report every year, and I actually have a meeting tomorrow. We give our annual reports, and the numbers are, I think almost like 95% have less than a 7-day supply when they're sent home. I think there's always issues with electronic medical records and really pulling the data better, because we still don't want to penalize someone that needs more than 7 days. But on the whole, we do have a lot of data showing that the total number of pills is way down, which I think is a good success for any hospital and for patients as well, that there's a lot less unused medicines that in the past that wasn't even a thought, right? Yeah, so we cover that. It's a little harder to pick up on the prescribing as outpatients. We can see it, but the numbers are a little dirtier, but we can see numbers of scripts by physician and things like that. But definitely on the inpatient side, it's part of our, across the system, even at the Providence level, looking at post-op prescribing.
Thank you. Providers are well aware and have been for a long time about this concern with over prescribing of opioids. Thank you for that input. I appreciate it. Any other comments or questions? Are we ready to continue, Ms. Boyd?
Yes.
Okay, the next item on the agenda is a presentation from the Washington Patients in Intractable Pain Patient Advocacy Group. Rose Bigham, if you would like to begin, please.
I would. Amelia, I am not seeing how to share my slides.
So in the PowerPoint program, there should be a little button in the top right that says share in Teams.
And
if
there
it's
isn't.
not there,
Yeah.
you should be able to start your slideshow, and then you should be able to hit the share button within Teams and share the screen that's doing your slideshow.
Start my slideshow and then what?
Hit the share button in the Teams in the meeting that we're in right now. There's a share button, should be in the top right.
Is that in fact sharing my screen?
It is sharing your screen, but it's not in presenter mode. There we go.
Yay. Thank you so
Perfect.
much.
Thank
Sorry,
you.
that's the first time I'm trying to do that. And ironically, I worked in like the Microsoft Office division for like a decade. You would have thought that would come naturally, and yet here we are. Okay. First, we'd like to say thank you to the commissioners for giving us a few minutes on today's schedule. It's important that we level set how we got here and to remind everyone participating why the stated objectives on the citizens petition remain critically important to so many patients and providers in our state. Quickly, for those of you who were not here and participating in the ESHB 1427 rulemaking process back in 2017, 2018, which created the rules which we are discussing. Cindy and I met back then at the second task force meeting in Spokane, and we continued attending those task force meetings all over the state through to the end, making public comments at each one. And we were finally included and consulted by the task force members, the Department of Health, and the Medical Commission as part of the process at the time. So we are both intimately familiar with the rules and how they came to be, as well as the impact they have had on patients and providers in our state. As a chronic pain patient, so how we got here, sorry, a chronic pain patient that was neither of us actually filed a petition to amend the prescribing rules because patients are continuing to be harmed by them, which was never the intent, obviously. The rules were made when we had very little accurate data on the true causes of the opioid overdose crisis in Washington, which we now know to be caused currently by illicit fentanyl over 90% of the time, according to the fine folks at ADI. We have 500,000 state residents over age 18 with severe high-impact chronic pain. While not all of them will be on long-term opioids, obviously, quite a few are, and they're struggling. WashPIP hears from people regularly, and I think Micah mentioned that the commission has been hearing from folks as well. So why was it filed? It said, this whole slide says it all. These are the things that chronic pain patients have been facing since the rules went into effect in 2019. We can't give you hard data on how many patients this has impacted because no one has been tracking patient outcomes this whole time. We just know, we hear from people all over the state. We hear from people as clinicians retire or close down or decide to lower their prescribing limits based on factors outside the state. The non-voluntary opioid tapering, that happened to me personally years ago, and it's what led me to that task force, and it is why I became an advocate in the first place. And this is still happening either to patients forced to taper to a subtherapeutic level to meet some arbitrary MME limit, or off of opioids completely for some non-medical reason. Even in the VA announced in a press release in September 2023 that opioid prescribing had decreased in veterans by 67% between 2012 and 2023. Over 500,000 veterans were tapered or removed from opioid prescriptions. And then in 2024, the National Veteran Suicide Prevention Annual Report findings state that the leading risk factor among veterans who died by suicide between 2020 and 2022 was pain, 54% actually. So taking people off of opioids or tapering them for non-medical reasons or against their will, it ends badly. And there's a lot of data to support that. So what's wrong with the rules specifically was they were written back in 2017, 2018, when we thought we knew what was going on, but we didn't. And not for nothing, they were written as they were at that time to prevent the legislature from further meddling into healthcare. They were written so cautiously that they have had the effect of preventing prescribing instead of encouraging thoughtful, cautious prescribing where appropriate. The goal of preventing any prescriptions from possibly being misused completely overrode the goal of ensuring that people with serious pain issues got medically appropriate medications. They are overly prescriptive, they are too detailed, and they are too long. Because the rules have the force of law behind all of these shall statements, it's made the potential disciplinary penalty for missing any one thing disproportionately severe for providers who do want to treat patients with compassion and thoughtful care. As far as the patient harms, articles in the American Journal of Public Health in 2022 have acknowledged that the clinical interventions focused on opioid prescribing have failed to deliver significant public health benefits while arguably doing harm. And just to sum that up, something like 32 states rushed to enshrine new prescribing limits and dose, duration, and number of patients into their state laws, rules, and guidelines based on the 2016 CDC guidelines. And now that we are all a little better informed about things, unringing that bell is lengthy and tedious, and pain patients are continuing to suffer while we all try to undo the things that got enshrined into laws. We are telling you, as patient advocates and peer counselors, and as pain patients ourselves, the rules are preventing people with real severe pain issues from getting appropriate care. The rules need to be updated to make it clearer, simpler for providers to do the right things for their patients within the standards of care. What do we know in one simple chart? This is data based that the AMA helpfully published for all the states from 2012 to 2024, pulled out of IQVIA dispensing data, and the overdose death data I pulled from CDC Wonder. And the blue line is the rate of prescription opioids dispensed per 100 people nationwide, and the orange bars are the all-drug overdose deaths. As you can see, the peak of opioid prescribing nationwide was in 2012, but the overdose deaths didn't begin to spike nationwide until 2014, the year after illicit fentanyl precursors started flooding into the country. That quote on the left, by the way, is from this book, Greed to Good, The Untold Story of CDC's Disastrous War on Opioids, authored by a 30-year epidemiologist at CDC. And there's this great, it's right, I just realized I actually own it. The quote inside the front is, the nationwide implementation of a seemingly simple, rational, plausible intervention by CDC had the paradoxical effect of turbocharging the opioid epidemic. And that's, I'm pretty sure, what these numbers show. The next slide is the same data, but for just Washington State. In our state, opioids peaked, the prescribing peaked at 2008, and our overdose deaths didn't spike until later than the rest of the country. But in the middle of 2008 and 2017 were pain patients who were being abandoned, tapered, faced with stigma at hospital emergency departments, pharmacies, some doctors' offices. The overwhelming majority of people taking their own prescribed opioids for medical reasons never misused, diverted, or became addicted to prescription opioids. And we have multiple sources to substantiate that statement. As you can see from our chart, even if we believed that people became addicted to their prescriptions and moved on to illicit drugs, the correlation would have started long before, when those prescriptions started coming down and the illicit use came up, we would have seen these deaths spike way sooner if it was something as simple as people took prescriptions and then moved on to illicit substances. The overdose and deaths would have increased just as the prescription rate started declining in 2009, and that is just not what happened here. A note about the misuse data. It sort of had this epiphany recently that everything we know about the rates of misuse is derived from surveys of people who misused, not the people who didn't. So this surely skews what we know about how risky prescribed opioids are. The most accurate data we do have for people prescribed opioids for legitimate pain issues is in retrospective longitudinal observational studies. For example, this one is just hot off the press. It was published in March of this year. Evaluated the incidence of opioid use disorder among patients newly initiating opioids to manage acute and chronic pain in the United States. 2.6 million people who got prescriptions for acute pain between 2016 and 2019. They stopped it before COVID to not skew the data. And of those people, the 1, 2, and 3-year incidence rates of opioid use disorder were 0.21%, 0.32%, and 0.43% among acute pain patients. And among chronic, it was 1.11, 1.52, and 1.92% for chronic pain within 1, 2, and 3 years. And that has been consistent among the studies that have looked at people with legitimately diagnosed chronic pain issues and long-term opioids. It's 98%. That's what the DSM says about opioid use disorder prevalence. That's what NISDA studies say. It's 98% of people who take prescribed opioids as directed, well screened for addiction or misuse, don't misuse their prescriptions. So as we look at the misuse data, I want people to try to remember, if you ask people who used heroin if they misused prescriptions first, people rarely asked, were they their own prescriptions or were they someone else's? And they rarely ask people like me or Cindy, who have been stable on our opioids for ages, if we ever misuse, because we don't. Okay, to sum up, in an era where providers continue to fear excessive scrutiny, not necessarily from the medical commission, but from DEA and the unknown, instead of attempting to read and retain thousands of lines of rules, providers are choosing to forgo prescribing opioids at all, even when it's medically appropriate for their patients. And that's something that we would like to change with this rule revision. In conclusion, our asks are to simplify them and to cut the more complex, nuanced guidance and move that language into best practices guidance like Jeb is suggesting. Because when they have the force of law, it becomes this overwhelming thing that people cannot dare forget. If we can have the floor guidance in the law and the best practices in guidelines, then people can take their time and understand the nuance without fear of losing their license or their livelihood. Provide clear exemptions for patients with high impact chronic pain and their providers, and allow providers to once again treat their patients with discretion, not as an MME number to be managed. I'm going to circle back real quick to see if any of you have questions, but I wanted to explain the next few slides I'm going to not show. They were just extra stuff that we just didn't feel fit, but thought we'd include them because they're sources for people who might have any interest. Just some good data from prominent pain specialists nationwide in the next slide. And then slide 14 has what we thought we knew about prescription opioids back then, which if you look at them now in retrospect, it looks fairly archaic and draconian. The rest are sources for the various assertions throughout this slide deck, which there were a few that I got since I sent this presentation in, and I'll be happy to send those to Amelia to circulate if anyone's interested. And then if you read only one paper, please read the Frontier in Pain Research article from 2022 about overdose opioid treatment admissions and prescription opioid pain reliever relationships in the United States from 2010 to 2019, in which it does a linear regression model on the amount of opioids dispensed versus hospital admissions, overdose deaths, between prescription opioids and all opioids, and the lack of correlation between those in glorious Technicolor. And if you're going to read two, please also read from the American Journal of Public Health, Undoing Harm in Chronic Pain and Opioid Prescribing, which was published again in 2022, which basically says trying to set right all of these policies and laws and guidelines about medicine is incredibly painful and difficult and taking a real long time. And in the meantime, we have patients in pain and providers confused and afraid. And we can't fix all of that, but we have an opportunity here to try to make some real changes in Washington state to make providers have real clarity and to allow patients to get the appropriate care that they have not been getting since these rules came out. And that's everything that I was going to talk about. If anybody has any questions or would like to discuss, please do.
Thank you, Rose. Does anyone have any questions for Rose or Cindy? I do not see any hands raised.
Are we ready to continue then, Ms. Boyd?
Yes. Thank you so much for your presentations today, everyone.
Yes, I was going to say that myself. Thank you, Ms. Boyd. Thanks to both of you. The next item on the agenda is discussion of the draft language beginning with WAC 246-919-915. At around 2:50 p.m., we'll wrap up the workshop and discuss our next steps. Up to you, Ms. Boyd.
Okay, so the next item is actually section 930, I believe. Let me look at what I have right here. Yes, 930. Okay, so we made a few edits to this section. Hold on, let me change something real quick. I know it's hard for people to see in my dark mode. Okay, so we had made some changes at a previous workshop to this section. All we did with sub 1 is we moved it from 2 to 1 so that the requirement is up front in this section. And then we have some suggested language that's along the side here. And then these are our additions to kind of answer or add in what is being requested from the person who sent in the petition. So Ms. Higginbotham. So again, all we did was move this sub 2 to 1, and now sub 2 is, or sub 1 is 2, if that makes any sense at all. And then we added in some additional things to when a physician should consider referring the patient for additional evaluation. So everything that's in red is something that we've added. So does anyone have any questions about what's on the screen, or do you have any suggested changes? Do you like these additions?
I like this addition, sub 2, or I guess it's, yeah, now sub 2,
Sub
right?
2.
I like this addition. Would you mind scrolling down just a little bit after EI?
I'm sorry, what page is this? I'm like looking from
13.
So it's not technically 13.
Oh.
I use the document that's a Word document. What's in the packet is different, but if you look in the packet, let me show you. If you're able to access the bookmarks, you click the little down arrow next to draft language, you can navigate to any section. So it starts on page 83 of the materials.
Thank you.
Sure. And for those who
I
don't
like
know,
this. I like this
I'm going to
information.
introduce you real quick, Dr. Lee. So Dr. Lee is one of our commissioners, and she was just late today because she's obviously busy.
Oh yeah. It's true that. um, yeah. So I like this section because it isn't pinned to an MED or anything concrete. It's a clinical judgment about when a prescribing provider may consider, it's not an either an order, but a may consider seeking expert guidance for further input. So I like this. I think it leaves a lot of room for the prescriber to make a clinical judgment that's patient specific and individualized to that scenario.
Rose, did you have a question or did it get answered or a comment?
I'm just thinking this is really, really wordy. And I
Mhm.
think if we could make it, I don't object to any particular thing in here. I think these are all great things, but is there a way to make it more concise? Like yes, if you have somebody under 18 or somebody who has complex medical or behavioral conditions that you don't feel qualified to treat yourself or treat for them, by all means, but like, can we make it more concise without losing the very good detail that's in here, I guess?
I mean, I can attempt to do that, sure.
I mean, I don't, like I said, I'm just skimming. I don't see anything that's leaping out at me that I'm objecting to. I mean, we already have, you got to refer for 120, right? That's in there somewhere.
Yes, because we are required to have a threshold.
Right, the statute. Yep.
Yeah.
Until I can convince some legislator to change that law, by
Yeah.
God, we got to keep it in there, which is fine. So what did we have in here before was just under 18 and
Under 18, and let's see what else we had. Or who are potential high-risk patients, but we've removed all references to low.
Right.
Yeah.
Which I am very happy about. So yes, I approve of that. I guess it sounds like we're defining what we would have considered to be high risk with real detail here so as to avoid saying high risk. Is that right?
I think
Yeah,
just in this section, yeah.
Yeah, and I think that it's for those who would read this, I think it would be a guide, right? To define it rather than just having sort of like a a four-letter judgment, high risk, without any definition of what that means.
Yes,
I
the
think
catch
this
there
is
is
more instructive.
the catch there
I
is
wish
for
it could be
those
shorter too.
For those who would read this is exactly the part where I stopped. Like, that's correct. If we think primary care is treating chronic pain, even under 120 MED, in any of these scenarios, like I challenge anyone to bring me that data because I don't think that's happening. And because anyone, this is literally addressed at primary care, right? Not pain specialist, this section, because it's the referral to section, right? Consultation.
Prescribe a pain specialist. But most commonly, Rose, you're correct, it's going to be a primary care provider.
Right. Do we think there are primary care providers treating chronic pain even under 120?
Oh, yeah.
Just
absolutely.
most of it.
Yeah.
Interesting.
Okay,
And
so go ahead, Dr.
Nice
Lee.
to shorten it, but I think that, the objective of being concise probably is less important than being correct.
Not if no one's reading it because it's too long. If no one's bothering to read it at all, then being correct matters not at all. Are these things something that we could have in best practices instead of as this is the law in the state of Washington?
Well, it certainly could be pulled out and put into guideline. Absolutely. Because the only requirement is in sub 1.
Right. If in fact we could move towards best practices, then we could put something in here for more complex, nuanced treatment scenarios. Please refer to the best practices or guideline. Right?
Well, unfortunately, we can't put that in rule. We can't put that verbiage in rule. We can't reference an outside document that will be changed and things like that. So,
and that doesn't currently exist. That seems.
I mean, the guidelines do exist. We do have guidelines for both patients and prescribers for opioid prescribing. So yes, we could certainly pull this out of rule because again, before this section was really short. So we could definitely do that. And I know that that is part of the ask from WISMA. So part of the reason why it's here is because this was the request from the petitioner. But if we put it in guideline as opposed to rule, that would still respond to the petitioner's request. Jeb, did you get your question or comment taken care of?
Yeah, the point I was going to make is this is a really good example of there being a statutory requirement in the 120 threshold, and then a lot of special attention and shoulds and things like that might be more appropriate for a clinical guideline.
Go ahead, Cindy.
Yeah. So, well, if we're going to shorten it, you don't need to listen to me. But if you're considering keeping it, the letter C about experiences declining function, I know that Maria specifically has been very concerned about declining function when it should say outside the usual disease progression, because a lot of us have advancing diseases and will need elevated opioid therapy over time. So just that's very important. I don't think Maria is able to be here today. So I just wanted to say that it would be outside the usual disease progression.
That and lots of these longer term incurable progressive conditions go up and down over time. So we'll experience a period of decreased function that may or may not recover. And we don't want people to have to change providers in the middle of something during a not unexpected period of their disease progression.
So I'm going to have to do a little bit of research because I know we had a requirement to address special populations. So I need to make sure that this part isn't in special populations. So I can look into that. Do you have a comment, Dr. Sanos?
Yeah, no, I know we're kind of stuck because I agree that the best outcome would be there would be a lot shorter document and there would be a new guideline, but separate from there not being a new guideline coming out, I hate to add something here, but it seems like it's always been focused on opioids. Most of the patients referred to our pain clinic aren't even on opioids, and the primary care doctor is struggling to figure out how to help them out. So I don't know if there's anything that's in here. This kind of almost sets up the idea that if you don't respond to opioids, then it's a problem, and then you send them to the pain clinic. It's really, even if a lot of our pain conditions don't respond to opioids at all, and they're not being used. So I don't know where you would add it, but it's like if the patient's not doing well, despite unimodal treatments, they should be referred to a pain specialist or someone that could help. So I'm not sure. I just wanted to throw that out there because I think sometimes we get so focused on just like opioid, yes or no, but that's so, I think less and less, most of our patients aren't even on opioids, yet I don't want that to be the self limiting factor of when a primary care doctor even thinks of sending someone to a pain clinic. I don't know if that makes sense.
Sure.
Separate from, I know you got to keep the 120 morphine equivalent in there, but
right.
God, I mean, I see a lot of patients that have never been put on an opioid, and we probably shouldn't at all. And they have a horrible pain condition and they need the right treatment. And, I'd hate to think that it's just this opioid, yes or no. If that doesn't work, we're not doing anything else, but I'm just throwing that out there.
Thank you. And we can certainly take that into consideration, but because these rules are all about opioid prescribing,
Opioid, yep.
that's kind of
Right.
why we focus on that. Okay, so commissioners, how do you feel about possibly pulling out sub 2 and putting it in the guidelines as opposed to keeping it in rule, with the caveat that I have to make sure that we don't have to address under 18 years of age as part of the special populations?
I think it belongs here. I mean, I think this is the right place for it. And we're kind of like talking about two different positions. Like first we say they're too long and so we should be cutting it out. And then on the other side, we're saying, oh, we don't want that there because then the providers that are reviewing it will feel too restricted. I think it belongs here. We're trying to outline the way that we want Washington State's physicians to treat pain with opioid medications, and this is where that would belong, in my opinion.
I'd like to echo that.
Dr. Chang?
Yeah, I'm just thinking as even though I'm retired, but as a primary care physician, I'm looking at this. I'm pretty much all chronic, pain, patients all have complex medical behavioral health conditions. So you're actually talking about majority of the patient population, which is what we're dealing with. It's really, if you have that statement in, that B, you pretty much kind of sound primary care physician would interpret it that what that means is that every chronic pain patient should be referred to the pain specialist, even though that's in purviews is that that's actually part of primary care is that we deal with people with complex medical or behavioral health condition. I think probably what would generate what get my attention is referring to is actually in C is actually just lack of a clinical meaningful functional improvement, and indeed require escalating opioid therapy without corresponding improvement in pain, etc. And E also the presenting elevated risk factors. So those C, D, and E is basically the meat of the statements of when to refer. I'm just thinking that if you put in B, it's just that pretty much include pretty much everybody in chronic pain, and you're going to end up with some people will interpret say, well, I just am going to send everybody to that pain specialist. When there's 99 pain specialists, then they end up into bottleneck is that they couldn't get in to see the pain specialist and they couldn't get the pain medication.
I think that's a great point. I think that's a great point. Yeah, B is a really all-encompassing bullet point there. And so I'd be interested to know what other people think, but I would be agreeable to deleting that particular one because I think the other letters and capture what we're really after.
This is Rose. I skipped over my presentation. Does anybody know how many actual pain specialists there are in the state right now? I tried to find a number.
Well, we wouldn't probably know that only because we don't license by specialty.
Right.
The only information we would have is those that have actually answered that question on the required demographic survey.
Okay. Well, I did query a bunch of medical directories, and the number that spat back out was somewhere between 294 and 341 for the state, which seems low, but honestly, I have no frame of reference on whether that's accurate or not. And if you look at like the number who are, board certified pain specialists, it's a much smaller number. Which brings us back to, so completely agree with what Dr. Chang said. All chronic pain patients have complex health. All of us. I've not met a person yet who doesn't have, like, if you had a single cause of your chronic pain, they'd fix it for you, but that's not how that works. So B is a problem for sure. But I think the others, to a lesser degree, are all the same thing. It's going to shove all chronic pain patients to pain specialists when I don't think we have near enough pain specialists, not even just Washington, but nationwide, to handle that. So what happens if the chronic pain patients who today already can't get care are now, the few who are with primary care are being told, yep, now go see a pain specialist. You just can't find one. So that's a real risk we should consider.
But I'm sorry, Rose. I think this says should. It doesn't say shall. And I agree with you. And probably the number you're talking about with pain doctors, a good number of those don't even see patients and do medical management or just do consults, which is not helpful. So it's an even smaller number of pain doctors. So I'm not saying everyone with chronic pain that's not doing well needs to see a pain specialist, but this says should. So to me, I think it's okay to include that. And I agree with taking out the B because it's too ubiquitous.
So it says should now. It has until now always said shall, which means every provider in the state since 2019 has been told they shall. So,
but it only included are under 18 years of age
and 120
and like, yeah. 120 and are potential high risk patients. That's the only thing it said before.
Yeah. It did occur to Cindy and I when we were talking yesterday about, hey, wherever you land with these rules, how will y'all at the commission evangelize the new revisions to all of the licensees in the state so that they are aware of whatever the new ones are? And this seems like one that would be a particular import to make sure people understand that this new section that says you must refer is now a should, not a shall, and new added language.
I think it would be similar to the way we did it before. We traveled around the state and went to anywhere they would take us. We brought a commissioner with us. We did a presentation to hospitals and clinics and physician groups and things like that. So, and then obviously we had it on our website. We can do CMEs. And then anyone who's like new to the state that prescribes opioids, like they got a license recently, there is a requirement to do 1 hour of training on opioid prescribing, and reading the rules counts as that 1 hour. So we do have all of that in place. Okay, so I'm hearing that we want to delete B. Miss Blake, I didn't get to you before we took questions.
Oh,
so
that's all right. No problem.
Do you have any other comments about what we've added into sub 2? And then both Dr. Lee and and Mr. Lopez said that they think that the rest of this should stay, other than I think we're voting to delete sub B.
I agree with that. I think sometimes I can appreciate brevity, but sometimes less is not always more. I think it makes sense to leave that in and take out B.
So Commissioner, I'm assuming the rest, like Dr. Chang, are you okay with us deleting B?
Yeah, that's the point I raised. It's just that, from a primary care physician standpoint, is that every patient we treat all have, some kind of complex health issues. So if you put that in, I can guarantee that a lot of primary care physicians going to say, oh, okay, well, we're going to send everybody to, the pain specialist, which is a bottleneck.
Okay, trying to catch up on that. Oh, Micah's putting the demographics in the chat. Okay.
Ms. Boyd?
Yes.
May I just say that to me, this entire section is very clear from a practicing provider standpoint, primarily because of one word, which is should. Should. Not shall, should. Meaning to me, in the English language, means to me, maybe I should consider this. in the event of the following below. And so that's why I think this is a very somewhat declarative and supportive statement to help guide and direct some of our providers out there who are not quite clear how to manage pain patients who really want to do that. And I think, I applaud the efforts to try to put the wording together to be able to support these clinicians who are maybe struggling with how do I treat these people, and when do I submit, when do I stop, where does my limitations end, and where do I then, or how do I then make the decision to send forward to somebody, to an expertise. Thank you.
Thank you. Go ahead, Jim.
Oh, just very respectfully, the word guide was just used in the context of a rulemaking. And just to reiterate the verbal comment from earlier, floor that most time the patient's being treated. Everything else, all the shoulds, all the decisions, all the things that should be considered, all the guidance, as has been stated on this, all belongs in a clinical guideline.
So one thing I want to say about that is that, the clinicians are saying they want it here. But besides that, it's been mentioned many times that most prescribers don't read the rules. And the guideline, I think, is like 5 to 7 pages long. But we want to add that. Like if we moved this part out of rule and into guideline, we want to add that into a different document that they have to seek out, because we can't link it in rule. Like Rose was suggesting, that would be great, but we
I don't
can't
think WISMA
link
would
it.
say. I don't think the medical association would say that physicians don't read the rules, and we've gone through great lengths to educate them on what they contain. So I just want to clarify that piece on behalf of WISMA.
Okay. Well, it's something the commissioners can consider, but it sounds to me like the consensus with the 4 of them that are here is that they want to keep, other than the one we deleted, in this rule. And then I just want to circle back to Cindy's comment. You had made a comment about the declining function. Can you repeat that comment? Because I did not capture it when you mentioned that. Sorry.
I believe it was on, excuse me, I got to see my screen. So it was on, was it C or D?
It was C, it's now
It was
B.
C, yeah. Okay, well, that's why I'm confused. So it was any declining function outside the usual disease progression, because you have a lot of people that's diseases are advancing, and of course, their function is going to go down.
I think it was expected disease progression, maybe.
Either way is fine, right?
Yeah, yeah.
Expected. Okay.
Or usual disease progression is how Maria had said it.
Like typical, something like that.
Okay, so commissioners, how do you feel about that addition to subsub B?
I don't have any comment for that, Amelia. Ms. Boyd.
I'm thinking, I'm just, while was,
Oh, you know what?
I mean, certainly if you add that, but it's just, that sounds pretty wordy. And then also, I think, I'm trying to think if I were in the shoes of referring, and I can, take that into consideration, but it's usually, if I'm referring just that, yeah, I don't see any lack of a clinical meaningful functional improvement. That will be the main part. And declining, function, um, can be taken into consideration, but it's not that usually that not why I refer the patient to the pain specialist.
Yeah, I'm also thinking about it too. I mean, I just don't think it's necessary. I think there's a lot of space in here for physicians and providers that are taking care of chronic patients with chronic pain medications to see the guidance for when to refer. And this like outside of typical or outside of expected, it just feels like extra words to me without a lot of advantage.
So are you saying to remove the whole thing or to take out the expected?
I mean, I don't think that this like small statement in the middle of B is necessary outside of the expected disease progression. I don't think that. I think just experience declining function, like just as it had been before.
Okay, but the part where we're talking about we all have progressive diseases and we will experience declining function over time unless there's a medical miracle that solves our issues. So if we are stable and being treated by a provider and none of these other issues apply, but our disease is progressing and we're having declining function, you think we should go to a pain specialist regardless?
I think there's a lot of variables here, and this one isn't an automatic trigger to be required to go to a pain specialist. It's just one of many suggestions for when to consider. So I'm not so touchy about like the situation of somebody that has a progressive condition. I don't think that this particular bullet point is insisting on any necessity to see a pain specialist in that situation. It's just one of many statements here.
If this was in a guideline, I'd agree with you. But this is the force of law, right?
I mean, I would go back to this is a should, a shall, and there's multiple points here. It's not, connect the dots so clearly that if declining function, then must go to pain specialist. That's not what this is saying.
And part of the reason we changed the shall to a should is because how do we enforce considering?
Yeah.
So,
And why is it in there if it's a should?
well, like Ed mentioned earlier, the reason it's here is because if someone is looking here, it's giving them, direction on when they should consider, like if they're not sure when they should consider referring to a pain management specialist. So that's why the commissioners want it here and think it's important.
So for clarity, the shall part is they must refer above 120 MED, no wiggle. And we think probably they must refer for under age 18 because of special populations, but we'll get back on that. Yeah. The rest of this is maybe stuff, might do, could consider, maybe, depending on the patient. Which again, why would that need to be in the law and not in a guideline or a best practice document?
Because they'll take it as law. I mean, we've seen since the rules were published, everything is taken on law. Everything is misconstrued, including the guidelines. And that's why this is being addressed, because they need clear guidance. The more stuff in it, the more confusion that happens. We're sitting in the hot seat. Every month we go to our providers. We're put through the ringer. We hear our friends that don't have care anymore. So we need to really think, is this something that needs to be in there? Because they'll take it as law. That's what happens.
I mean, how many times did you guys have to put out interpretive statements to remind people that the only rules that have the force of law in Washington state are these, not the CDC guidelines? But if you change these to have all the guideline information in them, then the force of law statement now includes a bunch of guideline stuff. which is what we were fighting in the first place, and the CDC had to revise because it caused too many harms. So I just making this more like a guideline instead of the actual, these are the laws that you must do, just I don't think solves the problem, which is why the petition was filed in the first place, which is make it simpler and clearer for providers to treat and do what they must do, and then have a guideline on how to do the more nuanced stuff, like are they or are they not responding to care? Are they progressing?
Well, one thing to keep in mind is that we are still directed to consider the CDC guidelines. That directive has never been taken out of law. So because we still have to consider that.
And that's in 1427, right? That you got to consider CDC and AMDG and UW and I don't remember. It was a list.
Right. So that's never been taken out. That's never been removed. So it's still things that we have to consider. But besides all that, the commissioners are the ones that ultimately make the decision on what goes into rule. And so my understanding of this conversation is that they want it in here. And so they definitely know and hear that these things could be moved to a guideline. They understand that, but they think it's important for it to be here. So unless the commissioners have changed their mind about that point, unless there's issues with the language as it sits now, then I think we can move on to the next part of this section. There is another part.
Can I ask, isn't what this new language, isn't that what's in the CDC guideline as a guideline? Some of it?
So I would have to look because it has been a while since I added this, but most of this was to address the request in the petition.
Right. I guess it seems, I'm pretty sure some of this is in the CDC guideline. At least it was in 2016. I can't really attest to 2022 because it got real long. But if it's in fact addressed in that guideline, then moving it into the law seems to be diametrically opposed to what these rules were trying to be in the first place.
But again, we had to consider it. So
consider, but not adopt, right?
Right.
Sorry, what does that legal definition mean? Consider the rule, the CDC guidelines. I'm not clear on what that actually means practically.
Well, I would have to ask Heather to clarify that.
I'm glad it wasn't just me, because
Go ahead,
I'm
Micah.
considering it.
I don't know where Heather is right now, but
I'm right here.
Yeah. I think it's important to point out in this particular instance that consider has more of a political impact than it does a legal one. So, while it does say nicely that we must consider these guidelines, it was made very clear to us that we needed to seriously consider what they said and try to align whatever we did with what was suggested. So the ones that I recall, it was CDC, AMDG, and I think BRE might have been listed as well. So those are the ones that we were directed to try and align with. And you're right, legally considered allows us to deviate. But it's a matter of degrees. I think if we deviate too much, how much attention are we going to get from those interested parties and legislators that want us to be aligned with what the federal levels and the AMDG were.
And this is Heather, and to add on to what Micah said, consider, it just means that during this process, you need to look at those resources and consider whether or not they're best practice, whether or not they have requirements you want to implement, but that you can deviate if there's a reason to. So those are just supposed to be things that you look to consider when you're adopting the rules. So it may be more of a political aspect, as Micah says, I don't know, but legally you just need to have looked at them, considered them, and you can decide whether or not to adopt in whole, in part, not at all. That's up to the commission.
I'm looking at 1427 right now, and it actually doesn't say BRE, Micah. It says AMDG, CDC, Department of Health, University of Washington, and professional associations, which I guess means JEB.
That's correct.
Okay, so I think we've established that this, for now, is staying where it's at. And again, this is not the last bite at this apple. We're going to have an open forum at the next workshop where you can talk about any section that's open as part of this rulemaking. So, I think we can move on to the next part where we added some things, which is, I think this is still 3. Yep, 3. We've added a new E. If you have questions about E, Micah is here to answer those. Commissioners, do you have any questions about this addition? I do not see any questions.
If a physician is using is trying to satisfy the consultation requirement by participating in a peer case presentation, how will this be documented? How will that be recorded? Especially if it is a case presentation that is not their own patient, but a comparable clinical case.
Yeah, so this came about pre-pandemic, and so the commission actually issued an administrative letter to the requester, basically stating that if you were on something like Project Echo and you didn't actually get your case presented, but something that was substantially similar was, to just document that in the record and say, you know, I attended such and such a thing, substantially similar case. This is the treatment plan.
Go ahead, Dr. Stanos.
Yeah, this is something I'm glad you have this in here. I think, you know, you stated this is obviously a little bit outdated. In our hospital, we are doing more e-consults where primary care doctors can reach out to us and we review the chart, and it's formally documented in the chart what our recommendations are. Sometimes that leads to the patients being seen with us, or we just give recommendations. Obviously, when this was written, I don't think we were doing e-consults. And so I didn't know if that's actually important wording, because it's been very useful for us, especially for primary care doctors to know that if they're in a bind and they have a quick question and they want to, you know, adjust the patient's, whether it's opioid regimen or whatever, that they can do that. So separate from Project Echo, which none of us go to. I mean, I know that it may be used in other places. We are using the e-consults and it's working. So I'm just kind of throwing that out there. I'm not sure if other hospital systems have that ability, but it does act in a way probably not as good as Project Echo that you're going over the case, but it can be. So that's just the thought to throw out there.
We're doing the same at our institution, Steve. How would you suggest adding any language here concisely that that would reflect that? Maybe like peer case presentation or review, and then deleting Project Echo, because that would capture Project Echo.
Yeah. Is it, you know, Project Echo, formal e-consult documented in the electronic medical record? I don't want to take it away from Project Echo, but is it almost like another version of that, you know? And again, I'm not on the commission. I don't know if that's something that would seem reasonable, because you are reviewing the chart and giving recommendations. It's a consult.
I agree with that.
The or similar is really meant to try and encapsulate other things that were not Project Echo, but, you know, would serve the same purpose.
Mm-hmm.
I actually have a quick question here. As someone who's worked in the community as an independent small practice, I don't think a lot of primary care providers have access to that e-consult. Um, if there's a way that we could make it more accessible to community providers, I think that would be amazing. But at this point, at least I'm not aware. Could maybe someone point out some resources? Because I wonder the practicality of it, right? Like where would like a primary care provider who's independently trying to do this, where would they find this e-consult resource?
Well, I work in an institution where it's like a sort of a captured population as the veterans hospital. So it would be kind of an internal resource, but I'm not sure how that works at other institutions.
Right, that's what I'm talking about, especially when we're also talking about like referral to pain specialists. And I think to Ms. Bigham's point earlier, I think that's really a big reality of tackling this problem is really finding enough resources for community primary care doctors who are trying to do this on their own. Because we also have to be mindful that these are the very patients who circle back and report their primary care doctors. So if somehow we could make it work, and I know this is beyond the scope of medical commission, but I think we just need to be mindful of these realities. These are ground realities, which I think most primary care providers who end up managing these patients, they face on a daily basis without much resources.
Any other comments? And then how do you feel about the addition of the commissioners of the formal e-consult?
I just have a question about the use of the word formal. Is that going to represent a barrier? I think people are going to be asking a question. What's a formal e-consult versus an
Or is it like a
e-consult?
documented, it's documented, right? Somewhere. Is that what we mean? It's,
Yeah, I think it just needs to be the key is it has to be documented.
Yeah, and you've got that at the last part of that section.
May document.
Yeah. I'm happy with that. I feel like from my point of view, we could move on from that, from E.
All right, commissioners, unless you have other additions or questions, we'll move on from E.
I just, thinking like being on the commissions, we're doing the, case, review and deciding, if when we review, really the documentation is important. So that means is that, if you do a informal consultation that's not documented, I mean, to us is that there's that it could be something, kind of pulling out of the hat, that we don't know if truly there's a pain specialist involvement. So that's really the key thing versus, like Project Echo, yeah, you can refer to, well, this I attend this certain day, and usually Project Echoes, and they usually have, just like this is recorded, you can say, oh yeah, that's the topic they're talking about that we can refer to. So I think that's the part. When I see an e-consult, I do want to see, that there's some documentation that yes, a pain specialist reviewed this, and there's from their review that's what we base on, in terms of from primary care physician standpoint, this is what we base on. Whereas as an independent, primary care physicians, the problem is that, yeah, if you get a independent pain clinic, they also in the private practice, they probably don't have the consult set up unless it's that they're, keeping up with the time. So I had the, luxuries of, it was practicing just like Dr. Lee and, Dr. Stanley was in a big system, so that there's the e-consults is no brainer. That's how they set up, make it as a resource available to the primary care physician.
So does anyone have any comment about Dr. Chang's?
Dr. Chang, were you suggesting that you'd like to see it stated definitively that an e-consult should include documentation?
Well, yeah, I kind of like the word formal, even though some people didn't want that. But formal to me is that yeah, that always involves documentation. E-consult by itself doesn't always include that, because it could be I just talk to them casually, like curbside consult, but there's no documentation. But if this complaint is filed, if we go kind of try to talk that, then it becomes recollections of the pain specialist. Did you or did you not talk to to this provider about this complaint, about this consultation? And that becomes very slippery slope because they could always deny. So I never been involved in carrying this patient because there's no documentation I can prove that.
How about just putting the word documented in front of the word e-consult?
I can accept that, yeah.
Because formal, informal could be a little confusing, but documentation is cut and dry. Is it documented or not is clear.
I'd like to echo the removal of the word formality. And certainly if our intention is documentation, I think we should be explicit and use the term documented.
Okay. Thank you, Ed. So with all of that, are we good with E, commissioners? Yes, yes.
Yes.
Yeah, I'm good.
Okay.
Yes.
All right, so sub 4. Let me see if I have any notes. I have no notes on sub 4, so I have no idea where this language came from. I added it, but I don't remember why. And I didn't make a note. So let's see.
This is Rose. I'm pretty sure this came from the petition originally, and the intent of it was if you're going to taper or discontinue anybody's opioid therapy for whatever reason, you need to document for whatever that reason was, why you're making that clinical decision. And the intent was that to protect patients from arbitrary discontinuations, but also if they transfer care to a new provider, it would be very helpful to have in your medical record why that decision was made. But now that we're looking at this under the if we're making this too damn long, I'm not sure. I mean, I'm gonna ask Cindy to weigh in here if what her thoughts are, because I'm thinking maybe it's way more words than we want, to be honest. And I don't think it actually buys us that much as far as protecting patients or clarifying things for future providers. But
well, and we repeat this language in the tapering section 950, that they have to document why. So before it just said a physician shall document each consultation with the pain management specialist. That's all it said before.
what does that mean? That they referred, or each time the patient sees them?
I think it means each time they referred. You're right. That's not very clear.
Because I don't think my primary care doctor has any idea how often I see my pain specialist or cares, or that would inform her in any way about my actual care. But I'm gonna let you guys sort that out because.
Oh, I think it means each time the physician consults with the pain management specialist, they have to document. I think that's what it means. Okay.
Can you show us the original language?
Yeah.
Thank you, Amelia.
Sure. Well, that's all it said before. That's what it says now in the rule.
So that just means that physician would include like a summary of the consultative recommendation in their own medical records. Does anybody else have ideas about what that means?
I think it just means that they have to just put in the record that they consulted with a pain management specialist.
Okay. Okay. That's probably a good thing. I mean, we would want to see that. I mean, if we have recommendations and requirements for when that should happen, then we should also expect that they can produce evidence in their documentation that it did.
So now the question becomes, do you want to leave it how it is now, or do you want to add all that other language?
I mean, you should confirm that that language came from the petition and not one of the commissioners, obviously, because I can't speak for them. But if it's from the petition, I think I'm comfortable saying I don't think we need the extra stuff.
Yeah, so it's saying may, right? You may document, not you shall document.
It says
So
shall.
The shall.
Yeah, shall document.
Okay, I'm looking above. Sorry.
Yeah, this is a different one. We're talking about sub 4 now.
Yeah, my eyes went up to the other one. Thanks a million.
Sure.
Does it also mean that if a PCP is attempting to find a primary care and their clinic isn't successful in finding a pain clinic, would that documentation suffice under this number 4, that the patient hasn't really made it to the pain specialist yet, but the clinic is attempting, right?
I mean, I don't think so, because this is saying that each consultation will be documented. So if they haven't consulted with anybody, then
right. I'm just wondering what happens if a practice is not able to find, because there's a lot of Medicaid patients who are not accepted by a lot of pain clinics in the area. So what do we do about them?
we don't have any caveat we don't have a carve out for those folks. And that's not what this is addressing. It's just saying that anytime a physician consults with a pain management specialist, they put it in the patient's record. So I don't think that that's something we address in these rules when they are not able to find a pain management specialist.
I wonder if there should be some mention of that, because that is another reality of a lot of primary care doctors.
That's something we can.
Is the question? Excuse me. Is the question what do they do if they can't find a referral?
They can't.
We do address that.
Oops.
We do.
We do. Where is
it?
it?
It talks about documenting an attempt to find a referral.
Oh, nice.
I don't know where it is.
Oh, it's probably in exemptions.
Ah, okay.
Which we're about to get to.
Sounds
okay.
Good. Okay, no problem.
So I have a note of it in case it's not in there, but okay. So headphones are acting up. Okay, so do you want 4 as it is now, as it is already in rule, or do you want to add all that other language, commissioners? Dr. Lee says leave it.
Well, I had heard it stated that language is elsewhere.
Right. The tapering piece definitely is elsewhere. So not I think the tapering and maybe, oh my goodness, just ignore that. The tapering piece is definitely in the tapering section, which we won't talk about today.
Yeah.
Because we only have like 1 minute left in this meeting. But
why don't we just put a pin in the tapering section conversation that we'll consider adding some of these other changes to the opioid regimen in that section, but this part right here, it seems sufficient for its purpose to leave it as it is.
So we definitely won't put anything in there about continuing in the tapering section.
Yeah.
But there is language about documenting why it's being tapered or discontinued.
Yeah.
So
Yeah.
okay.
That's appropriate. I believe that's appropriate. Nobody complains about continuity of their opioid medicines. It's when it's being changed that people want to have justification.
So you want to leave 4 as is, commissioners?
Correct, in my opinion.
Yeah.
Yes.
Ed? Ms. Blake?
Yes. Yes.
Dr. Chang?
Yeah, I think it's fine. I think really, continuing is not the issue. I just thinking that modifying actually encompass tapering and discontinuing because you're essentially talking about your change of plan. It's really the change of plan that's the issue here. So I think it can be simplified than just say any modification, should have a good, you had to have a clinical rationale. So.
Okay. Well, we will leave that as is then. Okay, I'm going to stop sharing the language.
So we will continue our discussion of the draft language at our next workshop. Thank you all for your participation. Ms. Boyd, would you please present our upcoming agenda items and discuss next steps?
So our next steps for this rulemaking are these 3 additional workshops. And then our the revised draft language, which we didn't make a lot of changes to today, will be available on this rules page within the next couple of weeks. And you can navigate to that by clicking this link on this slide. And then once that is posted to the page, we will send out a notification via our rules distribution list. Does anyone have any questions about these next steps? And then I'll talk about our upcoming agenda items. Don't see any questions. Okay, so for our next workshop, we will have an open forum where all sections that are open as part of this rulemaking can be discussed. We will also discuss any items from today's agenda that were not addressed. And then we'll review changes to the draft that were discussed today. And then we will talk about the proposed new sections from the Higginbotham red line, which is part of the petition. And then at the October 26th workshop, the only things on that agenda right now are following up on items from the September 28th workshop. And then we will talk about those 3 deferred sections that we have not, we discussed them briefly in the beginning of this rulemaking process, but there's going to be changes made to those sections based on the changes we're making to the rest of the rules. So it'll be the intent and scope, which is the very first section of the opioid prescribing rules, the exclusion section, where we can talk about adding that exclusion. We've discussed throughout this rulemaking process, adding some of the chronic pain patients that haven't had an escalating dose and things like that. And then the definition section will likely have some changes because we've added in some new vocabulary. And then the December 7th workshop should be the final workshop. That's my intention, is to have that be the final workshop. So we will follow up on any items from the October 26th workshop if we need to. And then at that workshop, the biggest thing that we will work on is a crosswalk of all the comments. And what that will include is a discussion of why where the suggested change was included in rule or why it was not included. So we have received almost 150 comments on this rulemaking that have been written. And so we won't go through every single one because many of them are similar or are asking for the same thing. So they'll be grouped into what they're asking for, and then there will be documents in the materials that will say, okay, these are all the comments that asked for this thing. This is where it is included, or this is why it was not included. And then we will finalize the draft language at that workshop. And all that means is that the commissioners who are on the panel for that workshop will give a go ahead for us to request the next step in the rulemaking process, and which is the 102 or proposed rulemaking. And we will do that at the January 15th business meeting next year. Does anyone have any questions about these upcoming agenda items? I don't see any hands raised. No questions in the chat. Great.
All right, if there are no other comments or questions that haven't been addressed, then I will close this workshop at 2:55 p.m.
Thank you.
Thank you all for your participation.
Thanks, everyone.
Thank you. Bye.